My name's Lauren Wiggins. I'm Director of Services at Bowel Cancer UK. I'm delighted to introduce you to Dr. Diana Tait, leading oncologist at the Royal Marsden Hospital. And Diana's joined us today to answer your questions about bowel cancer and coronavirus. Thank you for joining me, Diana. I'm going to jump straight into the questions.
Right.
Our first question is from a clinical team. How might hospitals reduce the risk of transmission when a patient requires a scan? And what are the implications on timescales?
Well, I think that if you haven't been into a hospital recently, first of all, you would find them almost unrecognizable. And they are just quiet places. And this is very reassuring. And these are kind of general measures that have been taken to reduce the number of patients going through, the number of visitors. So I think, first of all, the lack of friends, family attending with patients, and patients only coming into the hospital a few minutes before an appointment means that the whole place is much quieter. So that reduces the possibility of there being a number of people in one place. It means that it's much more likely you can keep the 2-meter distance and that you can feel more comfortable in the environment. I certainly do working there. I find it now, you go into a waiting room and instead of it being crowded with people and there being people standing because there aren't enough chairs, there are just 1 or 2 people spaced out. And as I say, they'll be called in from outside the hospital when their appointment is due. So first of all, that means there's a lot less people, a lot less possibility of contact with other people, and so less likelihood of meeting the virus. I think that in most hospitals, for any appointment, a scan or a clinic appointment, patients are being screened first. So you're likely to get a phone call to ask if you've got any of the COVID symptoms. And if you are, then, there'd be special measures and you'd be sort of not included in that day's load. I think with the scanning apparatus, that there is a lot of cleansing going on between patients. So if a patient comes in and normally there'd be a piece of paper on the couch which would be changed on the scanning bed, now between patients they are all using the sanitizer to cleanse the area, door handles, the whole thing. So the scanning environment itself is as clean as it can be, allowing for the fact that there will be quite a lot of patients coming through each day. And one of the interesting things is that sometimes when a patient's having a CT scan and hasn't got particularly bad symptoms or isn't known to have COVID, the signs in the lungs, what will be seen in the lungs, will indicate that this patient might have COVID. So if that's the case, when that patient comes off the bed, if there's any suspicion that they are positive, they won't have a test at that point, nobody will know, but that the room would be deep cleansed, so that the whole procedure there would be halted and patients obviously would have to wait. And I think the other things are that anybody that's suspected of having COVID, has got symptoms, will be put at the end of the day, which is sort of normal procedure for any infection in hospitals, theatres, outpatients. If you have somebody that could have an infection that's transmissible, you would put them at the end of the day so that after them, the room again could be deep cleansed. So, I think there's a lot going on that makes the whole environment much safer. Nothing is without risk, but I think that hospitals are taking great care to protect patients coming in for scans, and particularly as we're using scanning almost as an alternative to clinical examination at the moment in a lot of situations.
That's fascinating. And Diana, what about the implications on timescales with all of these measures needing to be taken?
Well, of course, it slows down the process so that the number of patients that can be scanned in a day is less. Many departments are working shift work partly to allow their staff to not overlap too much, but also to extend the working day so that more cases can be dealt with. I think at the moment, the increase in capacity because of these measures is pretty well met by the decrease in demand. So a lot of routine scans have been put off for the time being, and patients may be asked to come back in 2 or 3 months, that they don't need to have a scan at this moment. And a lot of patients don't want to come into hospitals at the moment. So I think it's balancing out quite well at the present time. How that will be in 2 months, 3 months' time, when the people that have put off their scans want to have their scans, when there hopefully will be some relaxation in the distancing, or at least in the exposure and coming out of the home, it may well be then that we will be more under pressure because of the need to have more scans, but we would still need to carry out these same precautions, I would think, for a very long time. Good news is we're okay at the moment, I think. That is only, I can't speak for all trusts, but I know that that's in our trust, and that would be the same, I think, the same sort of arithmetic in other trusts.
Great, thank you. Our second question is about shielding and being vulnerable. I am on the shielding list as I was having active chemotherapy. I have since finished, so does that mean I no longer have to shield and can go out for daily exercise? How long does K-pox make you vulnerable for?
And shielding is a challenge. It really doesn't stop. The need for shielding, as far as we know, doesn't stop when you finish chemotherapy. How long you need to shield for after that is not known. I mean, all of this is really, with this particular infection, is all new. But I think that the feeling is that at least 3 months, possibly 6 months, you need to not be going outside the home. You need to stay safe, stay home. And that's just because the chemotherapy will have had an impact on the blood count and on different components of it, which probably makes you, 1, more vulnerable to having and catching the infection, and 2, make you more vulnerable to getting the bad reaction with the lung problems. So I think it's something to discuss with your oncologist and also with your GP. Situations may be individually kind of manipulated, but I would say 3 months is likely to be the minimum. If you've got other comorbidities, if your counts remain depressed for a long time afterwards, then obviously you're going to be more susceptible, and it would be sensible to be cautious.
That's really interesting, and you say it is quite challenging. We've got a question that I'm going to come to now, actually, because it links really nicely with what you've just been talking about in terms of sort of the practicalities of shielding. So this question is, I am starting chemotherapy soon and will need to be shielding, but I have 2 young boys at primary school. When the schools open again, what does shielding really mean on a practical level during this time?
Well, that is a really difficult scenario. I think, strictly speaking, if you're on chemotherapy, you need to shield from other vulnerable members of the household, or should I say, members of the household that are making you vulnerable by going out into the community and coming back in. I think most people would say that you would need to be very cautious about contact with young children that are going to school at the time that you are on chemotherapy. And hopefully there's another member of the household who could take primary care of the children and be the ones that are doing the hands-on, very much hands-on, and that you as a parent with this vulnerable status would try to maintain a degree of separation. I think isolation is probably too hard, but separation from those children and keeping the 2-meter distance. I'm sure there'll be lots of different views on this and different guidelines, but I think you just need to really think about being separate during that time when your children are back in the community and potentially bringing the virus back into the home. So you may want to sort of almost self-isolate within the home, and as I say, at least at the minimum, keeping that 2-meter distance. A really, really difficult situation to be in. But the last thing you want is to get COVID while you're having chemotherapy. Obviously, we've said it could be worse than it would be if you weren't on chemo, but also if it interrupts then your chemotherapy, that may have an impact on, you know, the outcome with the cancer. So sorry, not kind of an easy one or a good news scenario, really sort of strict, I think, adherence.
And I think that really just highlights how complex and difficult the situation is for people at the moment. Our next question is also about chemotherapy, and something that you probably get asked quite a lot. How will chemotherapy impact my immune system, and how will this affect my risk of developing coronavirus?
Well, traditionally, we have always monitored patients who are having chemotherapy with blood counts. And it's the white cells that are the, you know, infection fighters. And within that, there are different components. And the neutrophils are the ones that we're always most worried about in a normal setting, because when they go down, they're the ones that make patients more susceptible to bacterial infections, to getting sepsis, as we now know it, urinary tract infections, pneumonias. And so the neutrophils are very important. And also when you're on chemotherapy, not only are the fall in the neutrophils make you susceptible, but the impact of the chemotherapy on the bowel lining means that organisms in the bowel are more able to enter the bloodstream and enter the body and create infection. So that's the very sort of standard situation with immunity and immune suppression on chemotherapy. But there are also a group of white blood cells called lymphocytes. And lymphocytes are probably more important in viral infections. And after chemotherapy, and often for a long time afterwards, and after radiotherapy as well, lymphocytes fall. And that's where we think that people may be more susceptible to viral infections. And it's also the lymphocytes that may be responsible for how severe a COVID infection you get, and whether or not you go on to develop this sort of lung situation, which is the one that we see a lot of on the in the media, and which is so distressing, and which is why patients can have very severe complications and fatalities. So I think, again, we're still learning a lot. We're learning a lot about the various immune factors in the immune cascades and how they have an impact on how your COVID symptoms develop and the complications develop. But certainly, it does appear that patients in the first 3 months out from chemotherapy and while they're on chemotherapy, and this is from data from China now, have more likelihood of becoming COVID sufferers and having more severe COVID.
It's fascinating. Wow. It's really quite complex, isn't it?
Yes, and just to add something else, it also seems that, you know, having a cancer on board has an impact on your immune system. So possibly, if you're having chemotherapy after you've had surgery and all the cancer is, you hope, removed, and you're giving it just to mop up cells, you're probably not as much at risk as somebody who's got cancer on board and who's having chemotherapy to attack and to sort of control that cancer. So there may also be an immune suppressing influence of the cancer being active, you know, in your body. So the more cancer you've got on board, probably the more at risk you are.
Thank you. This next question moves on to surgery. And so the question is, I was offered major bowel surgery after chemoradiation, but this has been put on hold since COVID. Is this safe?
Well, I think it depends what sort of response the person has had, or the tumour of that person has had, to chemoradiation. So we know that there are now about 20-25% of patients who, having had chemoradiation for a rectal cancer, will get a really good response and might form part of a group in which surgery can be deferred and perhaps avoided altogether. So we know that for a lot of patients, or a significant proportion of patients, rushing into surgery is not important. And in fact, it may be inadvisable, because if you just hang fire and wait, month on month, you may see continued response, and then you might be able to avoid surgery, which is something that's particularly important for patients who are going to end up with a permanent stoma, or the bowel very low down, joined up, so that bowel function is poor. But we also know that patients having had chemoradiation, that the response goes on for a long time. So even if the outcome of the first scan assessment isn't one of a complete response, we know that if you wait another 2 months, say, which seems like quite a long time, that the likelihood is there'll be a further shrinkage of the cancer. So certainly over the time frame of a few months, probably there is no harm in waiting to have surgery. And there are now a number of studies that have looked at this, and we have had a study which was a national, an international study, which looked at doing surgery at 6 weeks versus doing it at 12 weeks. Nothing to do with COVID, just, is it safe to wait? And we got more shrinkage the longer we waited, and more clear margins at surgery. The long-term outcomes of that study aren't yet known, but certainly there's nothing to indicate that it was a bad thing to wait 3 months rather than 1 month. So the only situation where I would see that having your surgery put off for a few months would be bad is that if the first scan you have, so you've had your chemoradiation, you have a scan, anything from 4 to 8 to 10 weeks, people vary when they do the scan. But if at that point there was progression, then it would obviously be a bad thing not to be able to offer surgery at that point. And hopefully anybody in that position would be put high up on the priority list to proceed to surgery. But I think for a lot of patients, a few months wait, provided we know they've had a response in the first place and they're being monitored to make sure that response is maintained, then it should not be of concern.
That's very reassuring. Our final question today. I'm having monitoring with scans and scopes after removal of an early bowel cancer 16 months ago. I should have had a scope in March, but this was cancelled and I only had a scan. What is the risk that a recurrence will be missed?
Well, it's difficult to quantify that in any sort of precise way. When we deal with early cancers, and you're saying it was removed, it sounds like it was a local excision, a local procedure, rather than a chunk of bowel was taken out. So it sounds like the cancer was scooped out, and that usually we would follow patients up with a scan which shows the wall of the bowel and the tissue just beyond the wall. With a scope, you're actually looking at the inside of the wall. And traditionally and standardly still, the scope is the most commonly used tool for picking up recurrence in the scenario you're talking about. So you would certainly want to have scopes done and not omitted. A scan will pick up some evidence of recurrence, and I think the two generally we use very much in conjunction. We use them together. Sometimes a patient will have a good scan, but the scope looks a bit iffy. Sometimes it's the other way around, and sometimes it's both. I think for the time being, if you miss one scope, I think considering we're often doing these at 3 monthly intervals, 12 weeks. So they're very frequent at the moment because it's a learning curve about local excisions that, missing one scope. I think if it were to be over 6 months, I think that does start to be something of a concern. But hopefully when we get to that point, scoping sessions will open up again. And I think just to reassure patients that there is already an easing and an expansion of what's available to them in their diagnostic services. Screening, which is based on scopes, is starting up again in the next couple of weeks. And there will be more scoping facilities gradually opening up. So again, it's going to be about getting priorities in place to make sure that patients that are at high risk don't miss 2 or 3 scopes, and that they get brought in as up to the top of the list, really, to get that scope done in a timely manner. But I think missing one scope, if you've got a good scan and you're asymptomatic, I wouldn't worry, but I would want my second scope.
Well, that's reassuring and interesting that you use the term sort of learning curve. I think everyone's learning quite a lot through all of this coronavirus, and cancer treatments is a learning curve constantly, isn't it?
It's amazing. The processes that we've had to think about, things that we've just done on automatic for years, and now we really are having to think about how to protect patients and how to get the best value out of the limited facilities that we've got. So I think it's a learning curve, and I think it's a useful one for a health provision service to go through. It's a shame that it's gone through it in these circumstances, but you're right, there are a lot of important lessons to learn.
Well, Diana, thank you so much for your time today. Really interesting discussion, and so fantastic to have your skills and expertise and insight in terms of the questions that matter to people affected by bowel cancer right now. If you would like information about coronavirus and the latest guidance, do visit our coronavirus hub on the Bowel Cancer website, bowelcanceruk.org.uk/coronavirus. Thank you. Stay safe.